Good evening, everybody. Welcome to the workshop on essential skills for psychologists organized by the Institute of Mental Health and Psychological Sciences. It's lovely to see you all here this Sunday evening. Thank you for taking part. So, before we enter the session, um, I take this opportunity to introduce the resource person for the day and the moderator for the day. The resource person for today's workshop would be Mr. Arun Selvaraj. So, Sir is a RCI registered clinical psychologist who has completed his MPhil in clinical psychology from the National Institute of Mental Health and Neurosciences. His area of expertise is in psychodiagnostics um, and in psychometric tool development. He has to his credits a number of scales and apparatus. It's a great pleasure to have you here amidst us, sir. Sir has served as a mentor for a lot of budding professionals, and it's really nice to have you here today. And the moderator for today's session would be Mr. Varun. So, those who attended our workshop on CBT would already be familiar with Sir. Sir has completed his MPhil in clinical psychology from the National Institute of Mental Health and Neurosciences, and his areas of interest are environmental psychology, psychodiagnostics, and interventions. A warm welcome to the both of you and to all the participants. A sincere request from our side to kindly keep your videos on so we can have an interactive session. So, before we get into the content of the day, I would like to call upon Mr. Varun to give us a brief outline about the upcoming professional training in CBT by IMAPS. Over to you, sir.
Right. So let me not waste much of your time. I'll just quickly wind up in 3-4 minutes, if possible. Yes. Yes. I hope the presentation is visible to you all now. So I'll straight away take you through the eligibility for the registration first. So we are specifically interested in training master's students in psychology, psychiatry, and also in psychiatric social work. And then this is how the course overview looks like. So this overall program is scheduled for around 12 weeks, which will be conducted on Sunday evening between 6 and 8 p.m. On whole, that will be of 8 lecture sessions. In addition to it, we'll also have different assignments and also in a role play setting. So as assignments per se, we'll be talking about topic presentation, case presentation, psychological assessments, and also case formulation and role playing techniques. And then one very unique thing about our course is that you'll also be given with 10 free case supervisions, as in 30 minutes of each session will be scheduled after the training program, right? Once you start practicing with your clients, you can have 10 sessions of supervision at different period of time, right? Yes, and then I'll quickly take you through the contents of the course. So these are all the elements which will be covered in the 12 different sessions. So we'll specifically intending to create 12 professionals per batches, right? So we are limiting the intake to just 12 participants per batch, so that we'll have you guys will have an hands-on experience, and we'll also have a close monitoring on your progresses, right? Right. And then the other details will be shared over a WhatsApp group to you after the session. So now I hand over the session to Mr. Arun Selvaraj. Thank you for your time. Over to you, Arun.
Thank you, Mr. Varun. Thank you so much. And I would like to extend my thanks to my IMAPS, which is one of the parent institute which have started working. And I'm very glad to be part of it. And I'm sharing my slide here. I hope it is visible and I'm audible too. Is it visible?
Yes.
Yes. Thank you all. So, and thanks for the introduction, Harshita. And myself, Arun Selvaraj, I'm currently practicing as a consultant clinical psychologist in a private hospital. Those who are not from Tamil Nadu, you might know somewhere around Kanyakumari. It's close to Kanyakumari. So it's 2 hours from Kanyakumari. It's a peripheral clinic. It's a tier 3 city. So it's not a city like Chennai. It's not a city like Coimbatore. It's a tier 3 city where I'm practicing. I've been practicing for last 2 years. And I've completed my MPhil CP from NIMANS Bangalore. And before this program started, I think I have asked some of the people to share their expectations from this program, and I think I can do justice. I have changed the tab. I think it should be showing the expectation part. So what I can get through from is people are asking about what are the rules and regulations, what are the laws, and how to increase the client base. And some people are like doing BSc right now and how I can go about it. And few people have asked about really good questions on what about the fees, how to ask about the fees and all. And these are the theme I can get from people who are responded to the forms which I've mailed earlier to them. So I think I can able to do justice on this with my practice, whatever I have right now. I'm sharing the slide now. I hope it's visible. So the content I'm covering right now is different arenas to practice as a psychologist, like where all the areas you can do your private practice, which is the first thing I'm going to talk. So second thing is private practice skill sets. I'm going to talk in two different aspects. One is professional aspect, which is as a psychologist, what are the things you need? And the second thing is as entrepreneurial aspect, what you are expected to know. And third thing is useful technologies and softwares, which are going to talk. And then fourth is something which is important. I think I feel this would be very helpful for me if someone have done earlier or some data is already there on this. So this is exclusive on who walks into the psychology clinic, which is associated to the psychiatric hospital, and their data which I have done. So we are still collecting the data, and this is from April to September. I just took this only for this topic, which is not yet published. So I just termed it as unpublished data. And I hope I'm clear. In case if you're not able to hear, like please feel free to unmute yourself or drop a message so that the coordinator can let you know. So I see private practice as a two different spectra. One is doing an independent practice, having your own establishment and doing your own practice alone, like all alone as an autonomy institution. And the other thing is having associated with some other bodies, some other stakeholders, doing as a freelancing person. So for doing an independent practice, as of now, Indian government requires any person who wants to practice as a psychologist, right now they need RCI license. And if you are opening a center, you can register with MSME. MSME is a registration process, which doesn't mean that you can run a clinic with that certificate, which means that you can run a very small business and you're registering with the government so that the government is supervising your financial transaction and the service what you're doing. See, RCA license is only given when you complete your BSc 3 years, MSc 2 years, plus MPhil in clinical psychology. Whichever institution have the license, if you're doing with that institution, you can get the RCI. And apart from this, people who have completed masters, people who have completed their bachelors, we do get a lot of internship students, and we see them, they're very enthusiastic in terms of practicing once they finish their masters. So for them, it would be better if they are practicing in schools, colleges, residential cares, if they are interested in working with student population. No, if you are not interested in working with student population, then the other major population you can look for is patient population. Especially you can work with any specialty clinics, for example, any cardiology clinics or any dermatology clinics or any cancer treatment clinics, because psychiatric populations with a lot of anxiety symptoms initially will go to the cardiologist. Psychiatric people who have a lot of dissociative symptoms, dissociative seizures, they do go to neurologist first, then going to any other psychiatric hospital due to the existing stigma which is already there. So it would be better if you are really interested in working with patient population, you can step into any specialty clinics, which can also help the clinician whoever is there to assist the service which they are giving. And then the third important thing is, if you are not at all interested in working with student or patient population, you can look for employees and professionals where they work in a group. For example, if you take any factories or any IT companies or MNC companies, they work in a group. They work together, they spend together. You can plan a program accordingly for them. You can also indirectly increase your client base. Plus, it can group interventions. Or else you can give type with an NGOs, any NGOs which is matching with your own values, your own value systems, in your own culture, or wherever you are planning to reside or wherever you're planning to settle down in your life. You can plan on with type with some NGOs. Moving ahead, the different arenas for a private psychology which we are talking is, these are the five different segments I can think of when you're going to do a private practice in association with these different institutions. Let me give an example. Assume that I've completed my master's. Am I audible? Is everything is okay? Okay. So assume that I've completed my master's and I'm very really interested in working with the student population. So it's better to look for school which is psychological minded, and plus you can actually look for discussion with the principal of what they're expecting from you and what the school is needed. In case if the school is, assume that I'm talking from the other side, I'm working in a school and I want to give a psychologist of a monthly salary of 20,000. I might expect the psychologist to do the office works and the clerical works and the other works, or to take some subjects to continue with whatever the revenue I'm giving to them. If that is the case, you can think and twist it little. You can make a tie-up with 2 to 3 different schools and you can work as a freelancing person. But make sure that the workloads are equally distributed. Make sure that you have enough manpower. Make sure that you're able to manage all these things. And this is an example I can give for you. So this apps for all the other all the other spectrums. Moving ahead. Okay. So if you're working in a private practice, then the RCA license might look like this. So this is the whole team which I work with, which I'll introduce it later. So RCA license looks like this. So it certify you as a rehabilitation professional in the category of clinical psychologist. So there are a lot of other people who get, like special educators who get certificate. So this is how it looks. So to get this, you have to complete your MPhil degree from any of the institutions which are accredited by the RCA. I'll come back to the comment section. There is a question. Well, I'll come back to that later. So to getting into the core private practice skill sets, I have taken into 2 different things. One is therapeutic skills, one is entrepreneurial skills. These both can blend together. For example, uh, assume that I'm being ethical. Ethical can be fit into both therapeutical and entrepreneurial skills. So moving ahead, so making a therapeutic framework, assume that a patient is walking in. If you are sitting in a private setup, you have assume that you have started an independent practice and you are sitting alone, either online or offline. So the client has come. What is ideally needed is the skill expected from you is, are you able to make a treatment plan? Are you able to understand why the client is here? Are you able to cater the client with whatever the expertise you have? So for that, to just indicate, does the client actually needs a counseling or not? So these are some things you can look for. Does the client have any difficulty in managing the emotions? Does the client have any excessive thinking? Does the client have unable to handle any stress or burnout? Does the client have unable to control their certain behaviors, for example, any addiction, impulsive behaviors? Does the individual have any substance or non-substance use addictions? Does the individual have any self-esteem related issues, or any trauma related concerns, or any major life incidents has happened? To make it very short, if you see the individual is going through something which is creating any distress or dysfunction in the individual or to the surroundings of them, can be an indication for a counseling. This is the very first thing you have to understand. And then how often you can give an appointment. Assume that the first session is always an intake session. I do know that there is a very mixed population, and I hope I can do justice. If you're not able to make it clear, please feel free to ask. Assume that if you are giving an intake session, fixing an appointment should be within a month, at least within a week, once in a week to once in a month, not more than like 3 months, 4 months, after 6 months, or like one sitting 3-4 hours, you can see the same client. No, that is not going to work. I do get a lot of clients from the other people. They'll come and they say like, we went for a couple therapy session. The madam was so nice and she took 1 3-hour session for us and every problem was answered and we were very happy. That is not how it's going to work. So the session should be at least from 30 minutes to 60 minutes. You can pace a session from 30 minutes to 60 minutes at least once a week or 15 days once. If the client is not able to make 15 days once, maximum you can go up to is monthly once, not more than that. Always work on appointment basis. For example, if you have started a private practice, fix what is your working time. It's always advised to have it in a office time, which is from morning 9 o'clock to evening 6 o'clock. Not more than that, not beyond that. Don't give your sessions at like night 9 o'clock, 10 o'clock, or like early morning 5 o'clock. No, that is not going to work. So make it because it's our work. So we do work in that time. So we do have our own families. We do have our own life things to do. So make it on the appointment time. And if it can go from 30 minutes to 60 minutes, and the appointment frequencies can be like from once a week to once a month, or like once in 6 months. Like once, if you that like the patient is getting better or the patient is doing well, the client is getting better, like you can pace it out accordingly. And how long a counseling should go. For example, I'm the patient and you are my therapist. If I'm asking that, like this is a very common question we get: how many sessions, how many classes we'd have to come? And exactly in Tamil they say like எத்தனை நாளைக்கு வரணும். So to put it in English, like they'll ask how many days should we come, how many sessions we have to come. So it's ideal that it's 3 months to 9 months, not more than that. So the number of sessions would always depend on the individual cases, resources available, and the progress and any comorbidity of the illness. It is based on all of these things, and it differs from case to case. So you can always explain that post intake or post the or the 3 to 4 sessions, we can tell that how it is going. Definitely you can't say that you come for 8 sessions, it will be better. I see a lot of Instagram reels which talks about you come for 9 sessions, your OCD will be over. You come for 3 sessions, your anxiety will be gone. I'm very surprised that like what magic they do. Like I technically know that it's not addressed what is the purpose is. Therapeutically, I know it's not going to help the client, but what they are marketing is not at all ethical at all. Like it's doing actually harm to the patient. And going further, cultural competence. So while I saw the registration thing, and currently I think we have around 108 participants. Is my audio is there? Someone have texted that there is no audio.
You are audible, Arun.
Okay, fine.
I guess there is
So fine. So cultural competence means, for example, there are around 109 participants are there, and all of them are across India, and few of them are outside India. So the place you have grown is different. If your place you have grown is different and where you're practicing is different, then I would advise get comfortable with whatever culture you're going into, because cultural competence adds a lot towards the belief system what the client carries. And I have spoken with a few of my friends who are practicing abroad. Initially what they face, they are good with techniques, they are good with their knowledge, there is no doubt at all, because I do know them personally. But when it comes to a cultural meaning, it's very difficult to understand what the patient is actually trying to say. Since we deal with thoughts, emotions, feelings, it has a very deep basis on the what the culture carry. So better to get into cultural understanding is assume that due to some circumstances you have to go to some other culture, means make sure that you're attending local functions, make sure you're attending, talking to the local people who are already there, and you can get some understanding from little old people over there, like what is happening, what is going there, and your friends who live there. If you're not able to understand, so I think some few of you all know like about the progress related discussions or like what reflective practices. And if that is the case, try to understand where are the areas you are able to see some difficulties in understanding the actual cultural meaning. So if that comes, then it would be better to get in good touch with what is happening in the culture. Even if you have a good rapport with the client, you can ask with the client in itself. I can give examples, but due to time constraints, I'm slowly moving up. And then I think this is one good question which is asked by some of the participants in the who are participating right now. Financial aspects. So as of now, I am working in a private hospital. All the building and maintenance things and all is being taken care by hospital. So I am not the major investor. Now I have a luxury to decide. The hospital have given me the independency to decide. I can decide how much ever I want. But considering the population who come in, wherever you're practicing, even it is online or offline or wherever you're practicing, always keep a range. You can have a basic fare. Assume that basic fare is 200 or 300 or 500, whatever, wherever you are living, whatever you're doing. And it can upskill to some amount. And in between this range, you should give an independency to the patient to decide how much they can pay. So this indirectly involves some commitment from the patient. So definitely don't charge very high without asking the patient. So I do hear a lot of therapy sessions going around. So this is one interesting case. So she's from my own hometown here, and there was some quackery practice, and that guy has charged as a package therapy. So he asked for 20,000 for some personality related concerns. He said 20 sessions you come, it is 20,000, but 20 session happens in 20 days. So then they are paid because the patients are very naive. They don't know what is happening. We are the one who we have to psychoeducate. Listen, this is not happening, going to be like that. So financial aspects, always keep a range. What is the minimum range you could accommodate? What is the maximum range you could accommodate? And if the patient says no, I can't, like I can only do this much, then at least do by that self. If you can't do, if the client have actual concerns, please refer to someone of your friend who is actually ready to do that. Because getting out for a help for a mental health concern is not at all easy for anyone. So if they have reached out, at least you can be addressed that sensitively to other one. Like we should cater what they are doing. So one thing I've realized in psychology is, so it's not a product we are selling. So product is you can sell and then you can give it them like, can you taste it and tell out of 10 how is it? So we are not selling a product, it's a service. Services can be only felt. So it's a little abstract. So sometimes we ourselves can also feel confused that am I doing it right? Am I doing it okay? What I'm doing is right or wrong? All these doubts will come up in initial things. So that is why all these courses, all these experts who are talking about things, the IMAPs conducting the courses, is also important to just build up our own knowledge and build up our own skills so that we can become confident in what we are doing. And regarding the financial aspects, try to be more and more ethical. Try to give invoice, try to make GST, make tax on it, and make sure that you are paying tax to the government. And all these things has to be very, very important. That I think the comment section is a lot of questions. I can come back to that. Okay. So these are some financial aspects I want to say. And it's a very controversial topic what I'm talking right now. But talking from the practice point of view, whatever you're doing as a justice, it should be get paid. There is no doubt in it. But the pay should be doing justice to whoever is receiving the service. You can't say like there is a patient from a very good socioeconomic status, he's from a political background, I can charge 10,000. No, that is not possible. That's not going to help. So what happens is it will indirectly create a pressure on you. When will the patient come? Like it'll be like we don't care about his anxiety is getting cured or not. We'll be like, when will the patient come? When will my pocket will become full? So that is not the thing we are doing. So make sure that be sensible on what you're charging. And I want to talk about what is not counseling. So and how you can be always ethical. So what is not counseling is, I think there are few CPs are there. Kindly excuse on this, but I also want to introduce this. Giving an advice on one side is not at all definitely not a counseling. So I had a case which I was telling earlier. So I went to one female psychologist, and she was talking for 2 hours, and she solved our problem. Everything was okay. So it should be conversational, it should be understanding, it should be empathetic. All these things should happen. And giving an instant solution for your problem, which is definitely not a counseling. Because nowadays there is some awareness is there. It's not like when I was started my UG, I don't even know what is anxiety. I don't even know what is depression. Like I know things, but I don't know technical definitions. But now if I ask some UG students, they can at least list out one symptom out of ICD, what is mentioned and things. So recently there are a lot of content outside, social media content outside, like do these many steps for depression, these many steps for anxiety, these many steps for OCD. Giving instant solution in the therapy room is not at all a counseling for sure. Just talking is not. Having a friendly chat is not. I had some of the client which is staying about, she's from Mumbai, and she was doing her some fashion designing course, and she used to say that me and my therapist used to go for beaches and used to go for some cafes and to have therapy sessions. And definitely it's not going to work. Therapy session should happen in a therapy space, and there should not be any other than therapeutic alliance should be built with the patient. And being judgmental, having a romantic relationship with the patient is definitely not counseling skills. So because I think Viktor Frankl is a guy who has written a book on the gift of therapy. In that, he has mentioned about what happens if a therapist have had a romantic relationship with a patient. It can ruin your whole year of study. It can ruin whole practice, whatever you have built. So if you're feeling so and so, it's better to go for a supervision. It's better to go for a discussion with someone who is superior or someone who is expertise in that knowledge. And then this is one more thing when it comes to private practice. I'm seeing it somewhere somewhere with my colleagues. So creating some sort of dependency on the counselor. So in therapy, assume that I am the client and you are the therapist. I've come for therapy and I have a lot of anxiety related symptoms. You're so nice, you're validating, you're asking everything, and you're doing what your job is. You're doing justice to me. So from my side, I'm feeling that I have not told this to anyone in my life. And this therapist is so nice. And I'm feeling that I should always come, I should always have a contact, I should take my therapist out, I should give to my therapist. All these things can happen. And if that is happening, you should be aware that. And the whole idea of being getting into therapy is you're helping the client to take care of their own problems. And this has more meaning than creating a dependence on a counselor. Yes, moving further. And I think we have spoken about what are the therapeutic skills. And these are the things which is definitely not a counseling. And going into entrepreneurial skill sets. So this set of skill sets, so I also not aware that there is something called the Community for Psychologists in Independent Practice. It's a division by APA. It's a division 42. I was not at all aware that there is a division. And when I came and read about it, they have a checklist of these are the things you can actually look for when you're doing your private practice. And there are some things which can be discussed in detail. Going ahead, first is entrepreneurial skills. Entrepreneurial skills, which mean getting an autonomy is not always easy thing. So autonomy is like gives you an lavishness to decide, giving you a lavishness to think, do what you want to do. And if you're not able to be comfortable or be confident on what you're doing, this autonomy can become a villain for you. So it will create a lot of self-doubt. It will create a lot of disparity in what you're thinking. And then, so since if you're getting into a practice can become will become your bread and butter. So even assume that there are 2-3 days that no patient has been turned up, and your revenue is zero. It's month end. These are the risks which can happen, and there are some risks like what are the private practice, like who is coming, who is going out, what are the different set of cases which is coming. There are a lot of risks can happen, so you should be able to anticipate the risk, and you should be able to address those risks effectively. And then you should have a critical thinking, having an accountability, like who is walking in, who is walking out, what is the data, and what is your appointment, like what is the revenues generated, and how you're investing it, how you're reinvesting it, how you're circulating it. All of these things you would be able to make it. And then being self-motivated, have a long-term business plan if you're having an if you're planning for an establishment. Long-term business strategy by mean, for example, assume that you have a long-term plan of building an therapy related institutions, or building an institution where you can train a lot of allied healthcare professionals like nurses, teachers. So it can be your own idea, but make sure it has a long-term plan. Going ahead, we need to be little bit creative in terms of time management, branding, revenue generating, marketing. And I want to specifically mention on time management. When I want to talk it in a business perspective, uh, assume that we are making a money using therapy and assessment skills. So psychology profession needs one-on-one, which means we need one qualified person to understand one patient or one client. So parallelly speaking, we need many people in the same time to multiply the revenue. So if in that is the case, we need a lot of qualified people. Assume that I'm talking in a business model. We need a lot of qualified people in the same time available, and they can able to see a lot of clients, and it should be quality. And these individuals should be supervised. These individuals should be given adequate resources in terms of training their own skills and supervising uh, their own cases, supervising their own progressions. All these things should happen. When it comes to psychology, the major drawbacks is we can see, you assume that there's one hour, one therapist can see only one family, or one therapist can see only one patient. And to increase the revenue, there should be like multiplicity of persons who should be there. And when it comes to branding, make sure that you are using local familiar names. Don't keep it as very complex names to understand. It will be high KPS. Any doubts? I think someone have raised their hand. You can drop a message in the comment box. And having a marketing plan, like there are different set of marketing plans are there. So what I see is very effective is getting referrals from word of mouth is very, very effective than doing any set of marketing. Is like, so there are marketing in Instagram. You can just create a post, pay to that Instagram, and select a location, and you can just boost the post. But it doesn't equate to what you get from word of mouth. Like, I've got referrals from some of your patient, I've got referrals from some of your student who have been trained there. That actually means a lot. It's actually validating when you start practicing. And having an overall business growth, assume that you're like one person now and you're increasing one more person. Make sure that employment benefits also is getting satisfied, and the patient needs also has been addressed. And when it comes to recruitment, track your data for at least for last 1 to 2 months, or 1 to 2 years, and see does it actually needs one more person. And if one more person comes, does it actually add well to the team? All of these things should be brainstormed priorly, so that it will not waste our energy. Okay. And a little bit I'm going back, and I think give me a minute. Yeah. So attention to detail is the other thing. Attention to detail by it means many patients come for many reasons. For example, if I can categorize people who come to our clinic, I can categorize it one set of people who come for just assessment. They want an assessment. They need to get an interpretation. We have to explain them, and we have to make sure that their understanding is in align with what is our explanation is, and then done. There is specific set of people who come for therapy. Therapy by mean individual therapy, couple therapy. These two I can make it as a broader spectrum. And one more spectrum which is coming up is family therapy. And then one more major group is comes for just for cognitive retraining and psychiatry rehabilitation aspects, where they to get into a lot of neuro rehabilitation and psychiatric rehabilitation related activities. And then the other major chunk comes for is group therapy. So we do have model for group therapy for alcohol addiction, group therapy for bipolar, group therapy for schizophrenic and remission patients. So what is very important is there are some peculiar case who comes for different reasons. Assume that I am a case, I have a court stand to, I have to like fitness to stand trial is happening next week. And you don't know at all that I am an MLC, medical legal case. I'm saying that I'm acting like a psychotic patient. Whereas sitting on the other side, we're very interested to see this case and we're writing very enthusiastically that the so-and-so patient is having some psychotic symptoms and you can refer to the patient, some problem is happening and you've signed it and put your seal. This can actually become a complications to our whole practice. So make sure that you are giving a proper attention to why the patient is here and why are here now and what they're expecting from you. This question should be addressed very clearly in the intake sessions. And then self-confidence aspect, it will take time if you are initially practicing. At least it will take 2 to 3 years of very rigorous practice, very rigorous supervision to gain whatever the self-confidence is. I do have my own self-confidence in specific areas of what I'm doing, but I do have a lot of areas which I still need to get expertise because I'm still like it's 2 years of practice of me. So it takes time. That is what is an understanding is. And then it's very strongly advised to have a very good involvement in technical and internet related knowledge, which I'll be telling you a few things right now. And then having a communication and listening skills, which doesn't mean that you're communicating with your patients, which means that you're communicating with local bodies, communicating with other government bodies which deals with people, like police stations, collector office, other people who other stakeholders who deal with common public. And then financial management, boundary setting with the clients, with the employers, with the family members, and then having collaboration with other different stakeholders. Having networks, I'll tell you that we get 3 to 4% of cases from astrologists and Swamijis. So we do have collaborations with them. So how it happens is people do go to Swamijis. So Swamiji, we teach them that what is psychosis and what is not he can treat. So ideally what do Swamiji do is like he do some puja and he do something what he wants to do. So that addresses the religious wants or the belief system which they carry in the patient system, and he also refers to the hospital. You can also go there and he'll give some tablets and there some counseling happens. You can also go there also. So they come through the population. So I was very amused when I was started my practice, like, oh, it's very surprising that how Swamiji is also sending referrals to hospital. And that can actually happen. And we will be discussing that data in later. So it will be very interesting. So yes, and I felt like since it's a very large group here, and I want to make it very clear that I'm assuming that you all started practicing and things are going well. So this is an important thing I want to tell, like when you should refer to a medical team. The first thing is when you see the client have self-harm ideas. Assume that it can be death wishes, active planning can be there, or if the client is having a just NSSI, like non-suicidal self-harm injuries, just to threaten, it's always better to refer to a psychiatrist or a psychiatric hospital or any PHC, physical, the normal general hospital. And then second thing is violent against others. If the client is emotionally overwhelmed, it's not at all possible that the counseling is going to work. So it's better to refer. And unable to take care of themselves, this can be a significant symptom of negative symptoms of schizophrenia or any psychotic symptoms. So if they have difficulty in taking care of physically themselves, so it's going to be very hard for them to take care of them mentally. And then does the client have any legal issues? Then refer to a hospital. If the client have any psychotic or mental illness or any organic issues, I mean, if the client is coming with any RTA, or brain injury, or any multiple seizures, epilepsy, all of these things coming, like it's better to send them to a medical team. And symptoms are not decreasing. This is very important. Assume that you have seen a client for 4 to 5 sessions, and the client subjectively says, I'm not improving, is different. You also objectively feel that the client is not improving. So it's better to refer to a psychiatrist. So I don't know, I can say this or not, but this can be a controversial thing, but I want to say. So the previous generation of a psychologist who I see right here, they have a clash with the psychiatrist people. Like, see, I can only see no, psychiatrist is not good in seeing, I can only see. No, I don't see that. Since been 2 years, I see a lot of cases. If we can clinically say that the client is not improving and send them for medication, after 3 months, if I'm seeing them, actually the client is becoming amenable to talk a little bit more better. And we do see changes in them. And that's a very meaningful change, not only for our practice, it's actually better for the patient and the family which is coming there. So if you see the symptom is not decreasing objectively, it's better to send them to a psychiatrist or any medical team so that they can see if there anything that can be done by medically. And the last important thing is, so all of these things are skills. So assume that you have tried all your skills which you have learned so far, and you feel like you're not capable of handling this case. Accept it, refer it to your friend who is good at handling this, and you get the updates. It's definitely not necessary at all that you only have to cure that case. No, it's not needed. The world has more psychologists. The world has more other experts. If you feel like it's not helping them, it's just to not waste the time. Just send them off. You yourself know, if you have a very good reflective practice, that like what you're doing with the case, you're able to sit and think about it. If the client is not improving and you also don't know what to do, it's better to go for supervision. If supervision doesn't work out, if discussion with some expertise is not working out, then it's better to refer to some other case. So it's a profession, it's a service. To give it another analogy, assume that I'm going to a salon. I don't like that people who is doing an haircut. So he is constantly saying that next time you will come, I'll try differently. Next time you come, I'll try differently. So don't experiment with the client. It's very, very depressing for them. So I think giving this analogy, haircut, it even hurts us. So think about what about the mental health of whoever is coming. So it's better to reflect on what you're doing. It's if they are not improving, it's better to refer, and then you can get updates like what is happening to the client. Is he okay or not? Okay, and moving further. So these are some useful technologies and softwares I can talk. So if you have some Gmail, that itself is enough. If you have G Suite, it is more than enough. So I want to tell some of the things, which is like, I think I can able to scribble it. Yeah. So I'm making a scribbling here. Which are the important thing is, so Excel sheet is for to maintain your data, patient data. So this and this, you can create a form and it can be linked to the Google Sheets. It will be help in terms of maintaining the data. So whatever I'm going to show further, it is being used from this. It's done. So for I think for Google Meet, you can use it for your sessions. You can use it for online sessions. And for Google Calendars, you can use it for given appointment. You can add the mail ID of the patient. It can actually go to the patient's mail ID, whatever time before you want to alert them, they will go there. So don't worry about it. So, and you can pace it out how many weeks. It will tell like how many times you have to repeat, 13 times you have to repeat, or like every Tuesday or every Thursday. You can fix it accordingly. So it will be easy for you to manage and to see every clients over there in the same sheet. And moving ahead, there is OneNote. If someone is like finished your masters and you're planning to start your private practice, I think I would advise purchasing some Tab is a good investment. Why purchasing Tab is a good investment is it can It can be a reading material. It can use as a reading device, and also it can use as a device which can be make a lot of notes and all. So it will be like all in one place. So it's easy maintenance also. So for free apps, you can look for OneNote, and people who are looking for iPad, you can have Good Notes, which is well and good, or Notify is also there. It's well and good. So OneNote has a lot of sections. So I'll just share mine. So I think it's not signed. Okay, fine. So I'll you can experiment by yourself. OneNote is well and good for making patient record maintenance. You can make a notes like different sections. You can make different case specific notes. You can make all of these things is easy for maintaining records. Yes. So I'll make a pause here. We'll have a question and answer, and then we'll go to the other further presentation. Or should I go further and finish it off and then we can have a discussion? Both are fine for me. So I'm in midway. I have only this the hospital data and the patient data is the pending thing. I might take 20 to 25 minutes more. So I can take some questions now. Hello, sir. I'm reading the comment box.
Yes,
So, yeah.
So before we moving on to the comment section and also on discussing on the unpublished data, I would share a few more insights to the audiences. Okay. And this was a wonderful presentation. I just wanted to mention, and then it was specifically to mention use of analogy, and then sharing your personal experiences, and also the note on the technical parts was very wonderful, Arun. Right. So adding on to whatever Arun has mentioned, I have listed out few pointers which is have to be added in addition to what Arun mentioned. So one is about the session timing, as in when it can be scheduled. So what I consider is that most of the clients who visits counseling setup would be predominantly working in during their office time. So we preferably can accommodate them and can preferably work till 8 p.m. is what I would suggest. Right. So we also work during their work time, and then they have to take leave and then coming to the session would again be a financial barrier for them. That is one pointer that has to be added. And then I'm also adding a few more exceptions. So what Arun has mentioned is predominantly the general practices. And then what I'm going to add is it's going to be an exemptions for all the pointers. Another section is about the duration of the session. So it has to be scheduled between 30 to 60 seconds or 45 to 60 seconds is what an ideal effective session that we can work with. And then in case if you're dealing with family thing or in terms of when it comes to couple counseling, we may have to stretch a bit and then can stretch the session up to 1.5 hours to 1 hour 45 minutes, if in case, right? If it is indicated, and preferably that the stretch can be happen in the initial part of the sessions. Initial part of the session, as in the process. So the initial phase, and then the middle phase, and also in the termination phase, because the first initial phases where they'll have a lot of things to be shared, and then we'll also need much time for us to understand them. That is one thing. And then another part is about the frequency of the session, how frequent the session can be catered. And then that also has to be in a phase-wise manner. Maybe in the initial phases of the time, we can have a session at least twice a week or thrice a week in order to conceptualize the case. And then when once we are entering into the working through phase, as in I mean with the middle phase of the therapy sessions, during that time we will definitely need to give them the enough time to process whatever that they have learned or got insight from the session, right? And then this is also another important point which I would want to add. So change doesn't just happen only in the session, right? Change will also happen between the session, right? So that's again another point. And then about the change the patients would definitely expect us to give some sort of promise that when will I get changed, or when my kid will get cured. So this will definitely be entered, and then we are also at a position to give them some sort of confidence or some sort of promise, isn't it? So in that context, I usually mention them after 5 or 6 sessions, we can find some changes. I'm not promising you that the person will completely change or they'll definitely be get all right. That I cannot be very sure of. But we can also promise them that after 5 to 6 sessions, you can find some changes. You can find some progress. Right. So that also been expected from us, isn't it? Right. Yeah. And then another point about the therapy condition. So where the therapy has to be taken place. Again, I'm pointing to the exceptions. In case if an individual has difficulty in social situation, encountering a social situation, not up to and social anxiety. And then the boundary part also has to be mentioned here. I'll take this point a little later. In case if an individual has anxiety when it comes to driving a car, right, which would definitely expect them to have an exposure session, right? In those contexts, we can obviously take them away from the therapy context, right? So these are all the general pointers. And then the last point which I wanted to add is about the boundary, right? So boundary here, I mean about the boundary between counseling psychologist and the clinical psychologist. That is very, very, very essential for us to understand, right? So when it comes to Mental Health Care Act, so they mentioned there are 3 sets of professionals who can deal with individuals having mental illness, right? Individuals having mental illness, underline the word mental illness, right? As in when the individual has got the diagnostic criteria, has met the diagnostic criteria according to DSM or ICD-10, that has to be intervened by a psychiatrist or a clinical psychologist or a psychiatric social worker. Understood? If in case an individual has psychological problems, for example, an individual has stress issue with managing stress, or issue with managing time, or issue with managing anger, or consider that they have low self-esteem, right? Or problem with their partners, or in interpersonal relationship, or a marital conflict, whatever it could be, right? If in case an individual has got no diagnosis or a mental illness, can be intervened by a counseling psychologist, right? Again, I'll bring you with 2 or 3 specific examples, which would again show some sort of insight into it. One part is about the adjustmental problem, right? So every college and most of the education institutes has a school psychologist or a student counselor, isn't it? So they have to deal with individuals having adjustmental issues, right? Every individual, as in when it comes to diagnostic criteria, we expect an individual to express or to have psychological expressions like anxiety, stress, depression, isn't it? These are all the common expressions which we can expect an individual to experience when they are in a new situation, right? But when we can diagnose them as having a adjustmental disorder, even after 6 months, if they not able to adjust to the environment, right, then we'll diagnose them as having an individual with adjustmental disorder. Before that, we just have them, we'll just understand them as having adjustmental problem, right? Again, taken into terms of grief. Grief is again a common psychological experience which happens after a perceived or an actual loss, right? Where a psychologist can intervene, as a counseling psychologist can obviously intervene. But in case if it crosses 6 months, right, the yearning, longing, or the preoccupation, right, or the depressive symptoms, or the low mood, loss of motivation, whatever it could be, if it persists even after 6 months, then we diagnose them as having complicated grief reaction, which again has to be dealt by a clinical psychologist. Understood? Right. So again, this is what the boundary issue that we have to specifically understand, right? So and then most of the time that we may not have a proper monitoring system in India, but we specifically stick with our own personal and professional values and ethics, right? So that's what I would strongly insist on practicing. So thank you. I'll again hand over the session to Arun Selvaraj.
Thank you, sir. Thanks for noticing, and thanks for adding upon it. It's really make it complete. Yes, I was reading the comment section. I will take 5 to 10 minutes, and then we'll jump into the slides again. So coming from the first, Payal Kataria, I'm sorry if I'm pronouncing your name wrong. Hello, sir. Can we work as a therapist by doing masters in psychology? You can work as an intern, but make sure that you're working under supervision, and make sure that you're seeing cases which is being just allotted by a supervisor, not you just take a case, like don't get an independent referral and then get supervision. So get a referral through someone who is already practicing and then get supervision in the middle of the session, so that at least you can improve your therapy skills. And then Ruta, masters in counseling psychology are not eligible for RCA license. That's a very sad thing. I think currently Allied Health Sciences is working on it. And I think I would ask Mr. Varun to add something on those lines in later presentations. Yeah, so going ahead, Harshi has asked about, should we let them know the individual about the next session, or will they ask for the next session? That's a very good question. So when you end the session, you will tell about, so when can we meet next? So you should discuss with the patient about the date and the time. And if the patient is not turning up, if your practice allows to give an alternative date, you can also give an alternative date and time. And make sure that the patient is coming on time. Assume that Haji, you are the therapist for me, and I'm coming for you as a patient. And you have given me time at 5 o'clock, and I'm coming like at 5:30. 5 to 6 is the session. So it's advised to stop the session by 6 o'clock. So whatever time you have been given, the patient should be there at on the time. And because as a therapist, we do have many patients lined up, or we do have other commitments to should be going on. So it can't be changed just coming late from wherever they're coming. If it is a genuine reason, assume that like they have called you and told that I'll be changing. So assuming that your contract is saying that if you want to change the appointment date at least within like 1 week or so and so before you have to inform me. It can be differ from what you're practicing and how you're practicing and how many cases you're having on the pipeline. And I hope I answered the question. And then Anita has asked about ethics of using social media. If you can later elaborate on that, would be helpful. Okay. So ethics of using social media. This is my personal opinion. I can be wrong in all the way possible. I think giving advice randomly on mental health issues by a non-qualified professionals over online can do actually harm in the patients. I'll tell how. So assume that there is a quack who has completed psychology PhD, and so person is saying that, and he or she is practicing some astrology. So he is saying that go to this temple and do this meditation for these many times. Assume that I am a 35-year-old female living in some rural area. My husband is a daily wage guy. And I believe that, so someone said that newspaper says, someone from psychology says whatever he says is true. And this reel say, so this guy is whatever is the psychologist and I think I should follow. So I am strictly against if someone is saying something who is not qualified about treatment plan or diagnosis. I strictly against them. And against them in the sense of I feel passively aggressive towards them on making the damage towards the community. I really appreciate if someone is talking actual diagnostic clarifications, making awareness of what are the laws available, making awareness of what are the services available, where you can go, where you cannot go. All these awareness things should be made and not the treatment part. Because assume that you are making a reel saying that if you're feeling depressed, go and have biryani at 1 a.m. It'll be fine. I have had my biryani, still I'm feeling sad, and I become suicidal now. So it's becoming an indirect reason that you are becoming a reason for, like, it's a precipitating factor. So definitely do no harm. That is the very first basic rule of medicine. So if you don't know, shut your mouth. It's better to do not do harm. And then going ahead, some practitioners have 2 to 3 years of experience and they say they are supervisor. Validity or ethics? That's a very good question, Anita. So who can be a supervisor is a good question. At least they should have some 5 to 10 years of experience. They should have had a very good understanding about psychotherapy researches they would have done, or some reflection related therapies they would have done. Assume that if you're asking me, can I supervise? I can supervise someone who is handling the area of cases which I am comfortable discussing with. And this supervision is not like a posting you get. Supervision comes through experience. Like, experience is not always correlation with number of years. Experience can also come through from studying, come through from understanding, come through working with some professionals who has already expertise in the area of. And those are the things can do justice in supervision. And in the name of supervision, some shit is happening, you're able to understand, then just stop the supervision. And we do had some example of some students saying that, so I had so and so experience with my client, so I went for my supervision with my supervisor, and he said something about reliving experience and he did something wrong, so I don't know how to deal about it. So it'll become like a total mess in the head. So supervision, it would be better if you know them professionally and they are the expertise in the area of whatever they are, and you can go and actually discuss with them. If their time allows, if they are ready to give supervision, then it's good. If it is not, then go back. You know how to read, you know how to you know how to read it, and it's go back and search for the articles and think for it and come up with your own hypothesis, and then go for a peer supervision. Like, discuss with your friends, at least discuss with your colleagues, and discuss with the patient itself. See, these are the things coming up. I'm talking in terms of case specific. I'm not talking the personal aspects of the therapy reflections. And I hope I answered that question. And then Deepika, after doing MSc conversion course in UK, can we practice in India, and what are the further opportunities? Right now, as what medical people have, that they have to write an exam to translate their license from the abroad to India, there is no specific body which is right now which is available to do that. And to you, Deepika, what I can think is it's better to get culturally competent of where you're going to practice, and then you can start. So it's assuming that you have completed your MSc from somewhere in the globe, and you are quantified, like you're qualified to understand theories which is in backup, and make sure that what is the area you're going to practice and with whom you're going to practice. Since you don't have license in RCI, and right now the Indian government is not appreciating you to practice independently, it's better to get associated with someone. And then ethics of following up with patients who hasn't resumed the session after pre-decided break. Yes. So Ruta, that is a very good question. So I think please remind me this question when I was talking about the average number of sessions people have actually come for the clinic. So we have a follow-up data. I'll talk. It's very interesting. I'll come back to that. And how to maintain confidentiality when the family members brings in a patient for therapy, and how much should be disclosed. So regarding the confidentiality aspect, definitely when the patient is saying or expressing any suicidal ideas, you have to open it up. There is no doubt in it, because it's matter of life. And remaining other content should be remain same. Whereas it differs from case to case. Assume that the case is from college student, and you just know the student, and she is living in college, like residential, and the parents are in somewhere 8 hours away from the family, and you should initially get the person who you can contact if the patient is not taking the phone. Because when I was doing my MPhil, we got panicked. This is the student from some of the private institution in Bangalore. She was suicidal, and suppose she has to come to the day. It's my friend's case, it's not mine. She used to come for the session. On the day she didn't turn up, and she wrote a long message. So usually before any death wishes, there are some signs after, like they'll write death notes, they'll say last words, they'll say goodbyes, all of these things they do. And she gave a hint that she's going to end her life. So we forgot to get the other number. So we tracked the college number, we called the hostel, we tracked the warden, and we thankfully we stopped it before she doing it. So so it's better to get always when it's suicidal, you have to inform the family members, one. And when it comes to child cases, There are some things you can open up. For example, recently we had a case about school refusal. He is not going to school, and we was asking him like, what is making you to not going to school? And we kept the parents away, and then we asked like, there is some teacher who is constantly scolding me, and why you told this now? And he was like, who now never nobody has asked me, keeping me alone, and don't tell to my parents, they think I'm weak. So these things you can open up, like lately to the parents, make them aware that, see, your son who is having so and so symptoms. If you are not opening up, you are unconsciously making the family to make dependent on you to come for a follow-up. So you should make the family to treat their own child. You should work with the parents in treating their own child. And we are from the expert side, we should give an advice that this is what is happening in your child. And we have to just wait and see how the parents is handling that. If they are not making it, then we have to see how they're doing it. Going further, Shivangni Garg, how can we know if a clinical psychologist fair follows? I think you can read about how to create an invoice using PAN number, and there are websites available. And you can also create a payment gateway, and that can also track your payment portal. Since I am working in a hospital, I am not familiar with this, but these are the things some of my people are like known people are doing. What in the written form to be provided to the clients, like documenting or anything? So this question I'm not understanding it properly. Can you make it clear? If anyone understands that question, please tell me out. I'm not
I think
understanding.
Shivingi is asking about a consent form.
Informed consent form.
Yes, informed consent.
Informed consent form in my hospital, I'm not getting. You can inform them about how long the session takes. What about the cancellation charges? So assume that if the patient has to book priorly for the time, like session charges is 500, they have to book 300 at least before they book the session. And in case if they're not turning up, how much you refund, how much you not refund. That part has to be told. And that form should have contact numbers of different people, significant others, and it should be cross-checked. And the form can also have a list of family members who are like where she's from and where the city she belongs to, the address, all of these things. You can that's the basic socio-demographic details with some written consent that the so and so person is reaching therapy on by herself or referred by so and so, and those things you can mention based on the place where you're practicing. It can differ, like if you're working in a clinic, it's different. If you're working independent, it's different. It's from school, but it's different. And then if RCA license is the mandatory requirement for private practice, what should counseling psychologists do? I think counseling psychology can get associated with the other professions, and I don't see it as like counseling psychologists have very less opportunity. Definitely not. They have a lot of vacancies. I think clinical psychology's opportunity is being scrutinized. Like they just deal with the patient population. The time is over, like 24/7, like thinking about me. But when it comes to counseling psychology, the field is big. They can play wherever they want to play. But make sure that you know what you want to play. And I think that is a very important thing. So just identify where you are interested in, where your expertise of knowledge is, and then you can work on it. Going ahead, sir, please address the supervision in private practice, whom to approach, which is the best method, is reporting everything to case of business. Okay. I think that is a very big question, and I'll just read everything. If a client facing any abuse, what's the representation? Rajalakshmi, whatever you have proceeded, it's I think I need a lot of time to explain what you're explaining that. I need a lot of information on that.
In the meantime, we'll take up the other questions. Sorry.
Yes. I think there are a lot of interesting question. I think I would request any coordinator to just summarize what is the core crux. Okay, coming back to the data. So you all can, I feel it is very interesting to discuss with you all, and I'm privileged to discuss with you all. So this is the data of our hospital clinical psychology unit. So this is our whole team. This is our whole team which works with us. So it has 4 psychiatrists, It has one clinical psychologist and 5 psychologists. And whoever is raising hand, I'll answer you later. Thank you, Gokul. And then we have psychiatric social work unit. And there is only one person. When the psychologist goes there and here, like we work in team. So we do give counseling and psychotherapy and psychological assessment. This is our whole work we do. So this is the data which we have taken from April to September 2024 from a clinical psychology unit in a very tier 3 city. Why I want to present this data is when I was completed my MPhil, I assumed that who comes to psychiatry hospital in my own place? Nobody comes. There is no mentally ill person at all. People are highly stigmatized and they don't even come. This was my stigma towards the people. But the total number of patients or number of sessions I have taken in this 4 months is 1,619, which goes to average of per month is 270. Average cases per day is 10 to 12. Average number of OP cases is 8 to 9 and IP cases is 2 to 3. So from this 1619, there are 762 patients and remaining numbers of repetition of the patients. So 762 patients data were taken and it's not yet published. So it is still going on. To understand this age frequency, so across all the ages patient comes. If you take little bit below 10, lot of ASD kids, autism spectrum cases, ADHD, behavioral syndromes, all of these things comes. But there is a peak, whatever graph you're seeing in the very below of the sheet, it's the distribution of age from 2 to 70, I think. So you can see there is a peak from somewhere around 10 to 25, 30, 40, till 40. So in that, both the genders are equal. So I thought many males will or many females will reach out to the hospital. That was my idea, but the data is not the same. Going ahead, I thought well-educated people only come for the psychiatry hospital, but the data is ulta. Till 10th grade people, till 8th grade people, and people who have completed diploma, polytechnic, post their 8th standard and 10th standard are the most number of people who have reached in. And 1 degree who have completed people who also came across. So it's which says that education is not matter. People do have their concerns and they are ready to get mental health consultation. And so I thought people who were families overeducated, they will be having good things over like reaching out to. They will have less stigma in terms of getting into mental health hospital. But it's still ulta. People who have studied till 3rd standard, assume this is the data of frequency of the qualification of the head of the family. Assume that if I'm coming, my father has studied like 3rd standard below. In that sense, I am the index patient. So the head of the family, if they are like below 3rd standard level, which is equal to not formally educated also, they are reaching it out. And then professional degree people also reaching out. So despite of any educational qualification, the service is needed. There is no doubt in it. And then frequencies of referred by. So I think there is someone who has asked about how can I increase my caseloads. So these are the different agencies you have to get in align with. So I don't think this whatever the mark is being made is logic, because astrology faith healers have sent 8 cases, which is very amusing for me. And then other people like major people, it's expected. Neighbors sending cases is high. Relative sending cases is high. By self is very high, which is very well and good indication of that people are ready to get consulted for their own self. So I think we should stop talking about people are having stigma, they are not reaching out. All these era is over. So now it's time to give intervention. And moving ahead, occupation of the individuals, and there is an error in this. So in unemployment, there is 307. We mistook that students, we also added as unemployed people. So the score is high. So cross-checking with the age spectrum, there are more people below 20. So below 20, they'll be definitely not employed. So there is an error in this. But taking that out, despite all the things people are coming up, but especially professionals who are coming for professionals, by mean engineers, doctors, Ayurveda Siddha doctors, all these people are getting into for psychological support is very surprising, which is 10% of the data. And also skilled workers who work in factories, who work in independent business. All of these people are coming up. It's very, very interesting to see. Like it's very like I feel mixed emotion of like I'm happy that they're reaching out, and I'm also glad that it's the whatever the work has done by our own seniors or pioneers in the area of psychology or mental health is doing justice now, and we are able to uh, do the intervention part, what they have taught us or what they have published. Going ahead, and then this is one more interesting. So did you or your family consulted any faith healers for this concern? This was the question we asked, and I want to ask this question. And it is very surprising that 24% of the people have gone through. So I don't see any logic in terms of psychoeducating the patient. Don't go to Swamiji's or don't go to mosques or temples to cure yourself. Let them go. You have tie up with them. So you should psychoeducate the Swamiji's and Pujaris who are there. Like, see, these are the symptoms of this. If you are having pujas, things and all happening, still the patients are not improving. Still the individual, you better refer to us. We'll take care. So I think that's a very boom in my head which happened when I see this data. And I think there was one more question I was addressing, right? Like so we had in this 4 months. So in this 4 months from April to April to September, how many sessions? Which is like 16 weeks. 4, 4, 6 April, May, June, July, August, September, which is 6 months. So in 6 months, there are many patients have dropped out in one sessions. So it's completely fine. There are many patients who have dropped out after 4 sessions. People who have continued more than 8 sessions are just 1 or 2. That can also correlated with the socioeconomic status where they fall. That can also correlate the availability and the reachability of the hospital where it is. So what I'm trying to say is, don't feel sad that the patient is not turning up on the appointment date. But make sure that whatever the given time, whatever the given session time is there, you're doing your job. And assuming that, thinking from the client's perspective, I'm talking in terms of hospital. I'm working in a hospital, so the data may be interpreted in a different way. If it is a private practice, I don't know how is it like, but I think it can mimic the same. Many people do not follow up after 4 sessions, 5 sessions. But our book taught us 12 sessions of CBT, 16 sessions of CBT, 1 year of DBT. This is what we taught. I think it's high time to make it culturally, ecologically valid to our own population. And I think this is the generation we are going to make that up. And when people ask, you can say that you come for 2 to 3 sessions, we see how is it going. If it is needed, we'll keep it up. And thinking from patient point of view, nobody likes to come to hospital because they feel it is sick, because it's private hospital, they suck money, and it is going to be very, very hard for them. And what will I say to my community? What will I say to my relatives? What will I lie to them? All of these things are in their head. And if they are reaching beyond all of these things, I think we should be able to do justice. And that should be in our head before we start seeing the cases. And even though the data had given me some sad emotions, but it creates some meaning in what I'm doing. And which means like we can cater more number of patients than catering very less number of patients. Like this indicates that the clinical psychologist to population ratio is less. So that is the reason it has to be like seen in a shorter term. You should be able to address many people. To take the study more meaningful, we need one more qualitative analysis of like why they have dropped out, follow up and all. That we are planning to do as a follow-up study. We keep that as a later, but this is the understanding we have. And yes, we do provide internship opportunities. And these are some institutions from Tamil Nadu have been participated as an internship. More than 100 students have come. I think few of my internship students also here as a participant. I'm so happy to see them. And these are the other state students who have been part of our institution for internship. They do go through a rigorous internship where they have to complete some assessments, complete some cases. They have to go for different postings. They have exit exam before they complete their internship exam, and they have viva, and then they'll go up. So Thank you all for giving this opportunity. I had a very good time with you all. And this is my contact number, social media pages, and my mail ID. If you want to take a screenshot, you can take it up. And thanks for being very interactive. Now we can address the comment section. We still have 10 more minutes.
First, thank you so much, sir.
Thank you, Ashita.
So the reaction from the participants, they're sending a lot of clap emojis. So I think that sums up pretty much how it was received. So before we go forward, I'd like to call upon Mr. Varun. So, sir, would you like to add something? We've had a series of discussions on a lot of topics.
Oh, sure. And then I'll also be adding a few more points which has been mentioned, and then I'll also try to, and then Arun and I will combinedly try to answer the rest of the questions for 10 more minutes. Right. So the first point is about the latecomers. Right. So if the session is scheduled between 6 and 7 p.m. in case if they come at 6:30. As Arun mentioned, that we have to straight away stop at 7 o'clock, right? Which I consider that it can, that's a right practice, but again, it can rupture the rapport. In that context, what I personally practice is that I'll tell them that I can give you 10 more minutes or 15 more minutes, and then I'll also request the other clients, if in case that I have another immediate session at 7, I can request them for 15 more minutes, kindly excuse them, and then that will again insist some sort of guilt in the client, right? So which I would personally practice, which saves the rapport, right? So that is one point. And then another important part is about practicing after masters and also establishing the clinic after masters in psychology. That was a consistent question which has been asked. And then Arun sir has mentioned that an individual needs an RCA license to establish a mental health setup, right? Again, that is for a mental health setup, which definitely deals to be where we are trying to deal individuals with mental illness. Right? For you to practice as an independent psychologist, we're going to treat individuals with psychological problems, as I have mentioned about time management or stress management, anger management, or relationship issues, or issues with self-esteem, procrastination. These are all the common psychological problems and individuals would be going through. To provide counseling for those individuals who doesn't have mental illness, you definitely don't, it's not like that you don't require. There is no specific organization or a body in our India which gives registration, right? And then even for a practitioner, or consider it as an RCA licensed practitioner, to establish a mental health setup, they should have a proper place, as in they should have at least 2-bedded room, right, where they can admit individuals, right? And then the people should have GST, and then the electricity should be commercialized, and all those aspects is there. That is for mental health setup. Again, that is for mental health disorders, mental illnesses, right? Not for mental health problems, right? And then again, practicing immediately after masters. Nobody will stop you from practicing, right? It is not about the law, or I mean, we are not mentioning from the rules and laws perspective. The other question about your competency, right? Are you really competent enough to practice immediately after your masters privately? Just stand in front of a mirror and ask this question to yourself, right? And then you can start your own practice. Even after MPhil in clinical psychology, consider that we both studied in NIMHANS, National Institute of Mental Health and Neurosciences. So we had 2 years of intensive training, right? So I would have, how many cases I would have seen during this 2 years? I would have seen 100 to 200 clients there, right? Possibly. Considering about the varieties of mental illness, there are around more than 400 varieties of mental illnesses. I wouldn't have definitely seen a lot of mental illnesses which my peer student would have, or peer trainee would have gone through, isn't it? So that doesn't stop me from practicing after MPhil, right? So there can be immediate supervisions which we definitely need to take even after having a qualified professional, right? And then about the year of qualification or anything regarding the supervision part. Again, it is about the question of competency, right? So supervision can be even done among peers, as in the practitioners with your own experiences or in your contemporary stages, right? Not necessarily from your supervisor or the seniors, preferably from the seniors, right? Again, we don't have any set norms to throw any light on it, right? Whatever the things that we are mentioning here is predominantly from our own experiences and what we feel right, right? And then some aspects that we definitely have laws and rules, right? As I mentioned about establishing a mental health setup, we have rules and laws, right? Okay. And then about the person who have studied abroad and wanted to establish the practice in India again. So you have to verify it with whether the university what you have got trained has equivalence with UGC norms, or does it comes under RCA norms equivalence, or we also have an upcoming law called, it's not an upcoming, like the regulatory body is going to come, but we had a law which got published in 2021, that I would definitely insist all the participants to kindly go through it. It's National Allied Commission on Healthcare Professionals Act, right? NACHA-CP 2021. Right, I would definitely insist you all to kindly go through that particular law for more clarity about your competencies and the professional practices, right? Yeah, so I hope I have answered most of the discussions, and then in case if you have any other questions, you can definitely ask. And then practicing as a counseling psychologist in rehabilitation setup with proper diploma courses. Again, the question is with the diploma provider, right? So masters, once and when that you have got trained or got the MSc qualification, you are free to practice, right? But I'm again, we need to check about our competency in practice. That is one point. And then even in a rehabilitation center, in case if you are dealing with patients having mental illness, right? Addiction is a mental illness, right? So again, that has to be intervened by a clinical psychologist, but we can practice under a supervision, obviously, when it is in a very structured setup, right? Where again, Arun is working in Sneha Mindcare Tirunelveli. He has 5 psychologists who's working with him, right? He takes supervision, and then under his supervision, they deal with individuals with mental illnesses, and then a sudden immediate monitoring will be handled or will be done by Arun Selvaraj. That is one thing that I have to add, right? Okay. Yes. And then handing over to the Arun.
Yes, I think pretty much if I am the participant on the other side, if I'm hearing this from my masters, I think I feel this is a good presentation. And the main intention behind this, making this free and making this quality of doing what we are doing, is it's coming from values of there is very less model of clinical psychologist or psychologist which I can look for and copy and then do what I am doing. Assume that if I'm going for a teacher or a professor, there are a lot of people who I can just model. There is zero model I can see in India, or like in, maybe they are expensive model, but it should be very easy to translate or transcend to the other generation or the other colleagues who are already there, already knowledge enough, and they just don't know what to do. And with that intention to address that problem area, I think this program has done a justice, and I really thank IMAPS for making this possible. And I hope you all enjoyed it. And I think I've dropped my Instagram page and other links over there. If you feel like following, you can follow it for more updates. And I think it's time. Thank you all for joining. Any other last words, Harshita? Okay, then.
Yeah. Thank you, sir. So again, like a lot of them have sent in a lot of feedback on the chat box as well. Thanking you both. Thank you so much, sir.
Thank you for coordinating, Harshita.
my pleasure, sir. So, participants, you'll be receiving your certificate of participation in the registered mail ID within 7 working days. This is only for those who have paid ₹99 towards the participation certificate. So we will be sending it to your registered mail ID within 7 working days. Thank you for being such lovely participants and engaging really well. It was a pleasure to have you here. Thank you.
Thank you all. If you are feeling like if you want to pay like now, you can pay also. You can get the certificate. There is no block in it. I think the institution provides that facility now. If you have come with some agenda that does this program make sense, then I'll pay. If you feel like so, you can do. There is no one stopping you.
But we've actually closed the Google Forms.
Okay, sorry then.
We've stopped the responses.
Okay.
In case if you're willing to pay, you can pay for the upcoming sessions for sure.
Yes. Thank you all. Bye. I'm leaving. It's a good
Thank
time.
you.
Thank you all. Yes, thank you for the session. Thank you.
Thank you, Varun.